to corneal conditions, when, how, and what to do. And without any further ado, I would request Dr. Geeta Iyer to please come and present her talk about surface reconstructions.
Thank you, Shweta. A very good morning to one and all of you. We will start with ocular surface reconstruction. We all know what the ocular surface constitutes of, and it is a derangement or dysfunction in one or more of these that leads to ocular surface disorders. The surgical intervention that is required to address the signs or symptoms of OSD that threaten the function or the structure of the ocular surface other than the use of a keratoprosthesis is what constitutes ocular surface reconstruction. The components of ocular surface reconstruction include the various components of the ocular surface by itself, and the first two on the left, which includes the tear film and the eyelids, is primarily to stabilize the ocular surface, and the main arms of ocular surface reconstruction include reconstruction of the fornix, the limbus, and the cornea for symblepharon or fornicial shortening, limbal stem cell deficiency, and corneal scarring or thinning respectively. So let's look at the scenarios which affect the conjunctival component. These are 6 different clinical pictures which more or less look similar as far as the conjunctival component is concerned. So is the management in all of these the same? Well, as far as management of conjunctival or fornicial reconstruction is concerned, we need to answer 2 questions. Do you need ocular surface reconstruction or not? So the need for OSR in conjunctival management is to improve vision, to improve motility, to improve cosmesis, to facilitate contact lens fitting, and as a part of a general ocular surface reconstruction. When will you not subject the above eyes to ocular surface reconstruction? When you're dealing with an immune condition, especially for cosmesis, when you have very dry eyes and when you have a keratinized surface. So what it means is that the first thing you need to know is what the etiology of the or what the disease is that you are addressing. And the factors that help in decision making include primarily the etiology, the laterality, the tear status, the limbal status, and the prognosis is determined by the corneal status, the age of onset, and the intraocular pressure. So when you look at symblepharon or fornix shortening, the most common etiologies that one comes across under the non-immune category is recurrent pterygium or chemical injuries, and under the immune category is Stevens-Johnson syndrome or ocular cicatricial pemphigoid. So when we look at a child like this who presents with a recurrent pterygium in one eye operated multiple times elsewhere, the questions that we need to ask ourselves are these, and this is what will follow through every case scenario that I will go through subsequently. So it's a non-immune unilateral condition with a focal limbal stem cell deficiency and a clear corneal status that does not require any intervention, and the eye is moist. So yes, we will go ahead with a fornicial reconstruction in this eye, and we have remained recurrence free for now almost 5 years following the surgery. This is another similar scenario in a patient of chemical injury where again the questions are almost answered very similarly to the earlier scenario, where chemical injury is again non-immune, and we did go ahead with the reconstruction, and this child again remains recurrence free for almost 2 years following the surgery. Now this is a situation very similar as far as the conjunctival component is concerned, but in addition to the fornicial shortening, you have a total limbal stem cell deficiency and you have corneal scarring, and therefore the management here would include not just fornix reconstruction but also limbal and corneal reconstruction. And this is a patient that underwent, in addition to fornix reconstruction, limbal stem cell transplant and lamellar keratoplasty with an improvement in vision subsequently. This is a completely different scenario where you're dealing with an immune condition such as OCP with again a focal LSCD and clear cornea. So here the intervention would depend on the underlying immune condition, and this is a situation where you would need to start these patients on systemic immunosuppression before you actually touch the eye. How it differs in OCP and SJS is that in Stevens-Johnson syndrome, when you're doing a phonics reconstruction, you might not need to really subject these eyes to systemic immunosuppression, and you might be able to control the inflammation with perioperative, topical, and systemic steroids. Again, this is a 8-year-old child with Stevens-Johnson syndrome. So if we answer the questions that are common to every case scenario, we would get an idea regarding our decision making in these eyes. So here we are not really sure of what the corneal status is. There is no thinning, but we are not sure regarding the clarity of the cornea. There is a total limbal stem cell deficiency. This is a child, this is a bilateral condition, and you would need to do something for visual rehabilitation, and this is a situation where you would probably need to take a decision between keratoprosthesis or a surface reconstruction, and in a child you do not want to subject the patient to a keratoprosthesis, and therefore you go towards ocular surface reconstruction in this patient with immunosuppression, considering the fact that this is a moist eye, and this is the outcome that we have had in this child, maintaining vision over almost 4 years now with an alloslet on systemic immunosuppression. In an eye like this, which is absolutely keratinized and dry, well, there is no scope for ocular surface reconstruction at all, whether it is unilateral or bilateral, whether it is immune or non-immune. And these are patients, when bilateral, are candidates for keratoprosthesis, but when unilateral, you do not really have too many options to offer. As far as the decision making is concerned, especially in chemical burns, in the chronic stage for limbal and corneal reconstruction, the decision is primarily based on the laterality and the tear status, which is what we had published in the management of unilateral total LSCD and bilateral total LSCD regarding how we take decisions based on the requirement of keratoprosthesis, the phonic status, the dry eye status, and the corneal status, with the need for systemic immunosuppression in bilateral patients. It's important to understand the rationale and principles of phonics reconstruction in these eyes, which I have divided into 4 main categories: the excision of the fibrovascular tissue, sealing of the gap, tissue substitutes that are used to prevent a recurrence, and the postoperative regimen, which constitutes of topical and systemic steroids as the need might be. So here, to understand the rationale, it's important to understand that what you're dealing with is the fibrovascular tissue that's demonstrated here in pink, the conjunctiva, which is in red, and the tenons, which is in green. And when you release the symblepharon, the gap that is formed between the conjunctiva and the tenons is what is called as the gap that needs to be sealed, so that you don't have the fibrovascular tissue coming back through it and leading to a recurrence. So when you have a mild symblepharon and you have adequate conjunctival tissue that is left behind, all you would need to do is an amniotic with fibrin glue. When it's a moderate symblepharon, you would need to combine it with a tissue substitute such as conjunctival autograft along with anchoring sutures. And when it is very severe symblepharon, you would also need an oral mucosal graft on the palpebral surface along with the use of amniotic membrane grafting. This is a very short video to kind of highlight the various principles that I just spoke about, where what you would primarily, the excision of fibrovascular tissue is something that we all are familiar with. It's important to enter into the plane between the conjunctiva and the tenons, and mitomycin C is always placed between the two and not over the sclera directly, which is what helps the prevent the recurrence. And then sealing of the gap is done using fibrin glue, as well as suturing the tenons to the conjunctiva, which prevents the fibrovascular tissue from coming out. And placement of the anchoring sutures is primarily done to direct the fibrovascular tissue away from the globe, so that you do not have it coming back and sticking onto the vulvar surface. Finally, the surgery is completed with the use of a tissue substitute, which in this case is a conjunctival autograft. And in certain situations, to help facilitate the epithelialization on the cornea, we do use alloslet to hasten the process of epithelialization. So these are again to re-emphasize the principles of phonics reconstruction. And for limbal reconstruction, we largely do know that it is autoslet when we're dealing with a unilateral disease, alloslet with immunosuppression for a bilateral disease. And when you have an additional corneal scarring or corneal thinning, then you would need to combine your reconstruction with either a penetrating keratoplasty, as in the upper panel, or a lamellar keratoplasty, as in the lower panel. Also, we need to be very clear about where ocular surface reconstruction will not work, and these are eyes where we would need to subject the patient to a keratoprosthesis. So, to summarize, these are the principles of ocular surface reconstruction, where you need to control the inflammation, stabilize the ocular surface, and then address each of the fornix, corneal, and the limbal components. Thank you for a very patient hearing. Anyone interested in a short-term ocular surface fellowship at Shankar Nethralaya is most welcome. Then these are announcements regarding the OSCON meeting in August and the Keracon in November. Thank you.
Thank you so much, Dr. Geeta. I think you have a question, sir? Yeah. Yeah, please.
Clear substitutes prior to condition during this what we can see, and then post operative. Any specific clear substitutes we have to use as a comprehensive ophthalmologist?
So this talk primarily dealt with surgical reconstruction. In these situations, you could choose any tear substitute. We are not specifying any particular category of molecule over the other when you are dealing with these cases. Where the need for selection would be very crucial is in a non-surgical situation when you're dealing with either an aqueous tear deficiency or a meibomian gland deficiency. And we have a very detailed write-up on the artificial tear substitutes in our first issue of the Journal of Cornea and Ocular Surface, where we have given pointers as to which tear substitute you would choose based on the underlying indication.
Okay,
Thank you.
Thank you so much. I would now request Dr. Rishi to please deliver his talk on anterior lamellar keratoplasty, when, what, and how.
Thank Dr. Shweta for including me in this wonderful IC. It's really covering the entire gamut of surgeries in cornea, from the surface to the endothelium. So my topic is anterior lamellar keratoplasty, when, what, and how. So when do we do anterior lamellar keratoplasty? Whenever we have a disease limited to the stroma. Okay, that means basically it's not just it's not a surface disease. It's not something which is involving the endothelium. It's essentially involving the anterior, mid, or posterior stroma, or all of it. Okay, so it could be scars, it could be ectasias of various types. It could be ectasias which have resolved with a scar and a hydrops, and even therapeutic indications like in certain infectious keratitis like acanthamoeba, etc., do well with lamellar keratoplasties. So it's important that we look at these patients on the slit lamp and make sure that the other layers are okay, and do the appropriate tests such as anterior segment OCT to make sure everything is in place and the endothelium is all right. If necessary, you can do a specular as well. So it's important to also understand the relevant new things in the anatomy of the cornea. We all know about the sixth layer of the cornea discovered by Professor Dua, which is essentially a predesmatic layer, something like a condensation of the posterior stroma, and it is really at this plane that we are trying to separate the stroma when you're doing a deep lamellar keratoplasty. We're not really detaching the stroma from the desmes, but it's actually from this predesmatic layer. If the pathology involves only the anterior stroma, say about 250 microns or lesser, then there are various ways to address it. You could, if it's very superficial, you could just do an excimer laser and ablate it if the residual bed is adequate. Otherwise, you can remove the anterior stroma either by means of a manual dissection, like is being shown in this particular video. So you can see that the donor cornea has been mounted on an artificial anterior chamber, and we're doing a lamellar dissection there as well. And then you basically put a 50% or so thickness of anterior stroma and suture it in place. You could also use an automated microkeratome to do the same thing, and that's when it's you could do away with the need for sutures. You could also use femtosecond laser to do the same thing. But if you're using a femtosecond laser or a microkeratome, you have to make sure that the surface is not very irregular. Otherwise, the bed that you leave behind will have the Xerox copy of the irregularities of the surface. So you'll probably have to address the surface irregularity first before you do a anterior lamellar keratoplasty. So where could you do it? Superficial scars, dystrophies. I'm not seeing the timer. Flap interface complications after LASIK, like epithelial ingrowth or some sort of if you've had a DLK or some other complication which has damaged the flap. Deep lamellar keratoplasty is the next important surgery in which basically you're removing the entire stroma essentially. And the various techniques of deep lamellar keratoplasty have been described. The popular one is the big bubble technique, but there are several manual techniques also which can be used. Essential idea is that you remove the stroma anterior to the predesmatic layer and replace it with fresh stroma from a donor. So like I said, OCT plays an important role. It helps you to understand the depth of the disease. So whether to do a anterior lamellar or deep lamellar keratoplasty, if the deep stroma is involving the predesmatic layer or the desmos membrane, then you may not want to go down all the way till the Duas layer or the desmos membrane, and you may want to do a slightly predesmatic dissection to prevent a perforation. Like in this lower OCT, you can see that the deeper layers have been damaged, probably from an old hydrops. This image is of a patient who's already had a DALC earlier, and you can see that the previous DALC was not all the way down to the predesmatic layer. So it helps you to understand if you need, after you remove the graft, whether there is scope for further dissection or you should just change the graft. Also, if you had an old perforation, any scarring, all that will help in planning. Topography also is useful because it helps you understand the extent of the disease on the cornea. So especially if you're dealing with an ectasia, you want to make sure you're encompassing the entire ectasia in your trephination. And I think topography with a large diameter is very useful in that. It's important to have the right instrumentation for trephination to obtain the dissection and as well as excision of the stroma. It's a good idea to have vacuum trefines for deep lamellar keratoplasty because you can go down to the correct depth, otherwise it's all very subjective, especially if you're trying to do a big bubble DALC. You want to be at the right depth when you introduce your cannula or needle. Femtosecond lasers, of course, are very expensive to refine, but yes, they do work beautifully well, especially for DALC. You can go for the mushroom cuts where you can remove more stroma and have a narrower posterior cut, and it will help you go to the desired depth. You can even make a track to introduce your cannula to get a perfect big bubble. And because the cuts are so well shaped, the new button also fits in perfectly like a manhole cover, and you can probably get better apposition with less astigmatism. Cannulas are very useful. These are big bubble cannulas. Many surgeons have designed some. Dr. Fogla has one, Dr. Sanikola, Tan, and many others have designed. And basic principle is that it's a cannula with a port at the bottom. So you're basically putting your cannula into the deep stroma paracentrally, and then you're injecting a small jet of air. The air finds its way through the deep stroma and detaches the predesmatic layer. You have dissectors also like these if you're planning to do some sort of a manual dissection. There are scissors which help to excise the stroma safely. So like I said, various techniques have been described, big bubble being the popular one. So this is what happens in the big bubble. You introduce air or sometimes even viscoelastic in the deep stroma and forms this kind of a feathery white bubble with a translucent center. Okay, this is called a type 1 bubble. This is a classic bubble, but sometimes if the air finds its way to the pre-desmos membrane space, it's more like a water bubble kind of a bubble which extends more peripherally, and that's not a desired bubble. That's called a type 2 bubble. So once you get a bubble, you remove some anterior stroma, you can puncture the bubble like so. It's called a brave slash. After that, if you want, you can introduce a viscoelastic in the interface. It's not mandatory to do this, and then essentially you are excising the stroma over dividing the stroma into 4 pies, and then you just excise them with a blunt tipped scissor like is being shown here. Then you go to your button, refine to size, peel the desmos membrane off it, and then you put your button in the bed and suture it with whatever technique is comfortable for you, interrupted, continuous. Femtosecond lasers, like I said, give you shaped cuts like these, and they help you reach the desired plane. And essentially once you've got the bubble, the rest of the surgery is quite similar. And like I said, because the donor is also shaped exactly, so it fits very well and can be sutured nicely. So this is what a type 2 bubble looks like. You can see initially we're getting emphysema. Left one is a type 1 bubble, and the right one you can see we're getting emphysema, and then we get a water bubble. I'm not sure if you can see it on the video there, but after we excise the stroma, you can see that little bubble outside. That's the type 2 bubble. So if you have big bubble, why would you want to do a manual talc? You don't always get a bubble like was just shown in the previous video. Extreme ectasias, the bubble doesn't go to the peripheral cornea. High risk grafts where you just don't want to have a perforation or a type 2 bubble, or if there's any other contraindication for a bubble like an old hydrops, etc., you may want to go for a manual. So traditional manual techniques are involve peeling layer after layer using a sharp instrument, but then there's a risk of perforation and you can end up with an irregular bed, and it's highly skill dependent. So we described this technique called the groove and peel technique, in which we make a partial thickness trephination. Here a bubble had been attempted, it didn't work. So then you basically do a scissor dissection underneath your groove, and you go all around, going with the closed scissor and then opening it. You can use any blunt tipped scissor like is being shown here. And then once you keep spiraling in circles till you reach this pre-desmetic Duas layer, which looks shiny and glassy like this. You expose about 2-3 cloacas. Then you just grasp that central island of stroma and use traction forces with the counter pressure from the other side to just peel that entire potential space open. And because you're using counter stretch forces which are distributed over a large surface area, it's less likely to perforate the cornea. So we've designed a scissor also for that with Joja Surgicals, which has a slightly narrower tip, and that works quite well. So this is just a representative picture. Again, in keratoglobus, it works very well because the attachments of the stroma are very weak, comes off like a LASIK flap. Therapeutic dalks also it works well because the stroma is edematous and spongy. So this is just that patient of therapeutic dalk that did well. This is a patient of surface like was shown earlier, in which we did panis resection and did a manual dalk here layer by layer using an iris positive for dissection actually. And this patient actually did quite well, and we were able to save him from amblyopia. So it's not that perforation doesn't occur. If you're very vigorous, sometimes, especially if it's an old hydrops, you can have, but most of the time perforations can be salvaged in dalk to get good outcomes. And you can see this one patient has had a big bubble dalk and one has had a manual dalk, and both are looking equally good, clear interface and compact corneas. Thank you.
Thank you, Dr. Rishi. I think Dr. Prateek has a question.
Dr. Rishi, when you're doing manual ALK, what is the preferred method of dissection recipient bed preparation? Whether it is with the help of lamellar dissectors, as we it's a closed, or whether you open it and with one hand you do a dissection with crescent?
No, I do on the recipient you're saying.
Yeah.
Recipient will be an open dissection only.
Okay.
Yeah.
Don't you think closed dissection with the help of a lamellar dissector would give you a better interface?
It might, so that could be done, but then you can't be sure that you're removing the entire pathology.
Exactly.
So after you remove, then if you're left with something, then again you'll have to proceed.
Okay.
So I just go with the like eyeballing kind of a thing, and according to that I decide how much to go deep in the donor.
Okay.
I don't do too much of anterior lamellar keratoplasty. They're very limited indications actually.
Yeah, exactly. Okay.
Yeah.
Very nice presentation. Just wanted to ask you if you are doing an anterior lamellar keratoplasty in indications like trachoma, where you have Salzmann nodular degeneration above it, when you do them, do you actually get the epithelial issues later on as well? And if you do get, what do you combine your surgery with, an amniotic membrane, or what is usually your way of dealing with it?
So if it's Salzmann, what in my experience it doesn't recur so easily, especially if you've taken care of the stroma and you've regularized it. Of course, if there's an underlying surface disease, that will have to be addressed. But I think you'll have to just do it on a case-to-case basis. If there is a surface problem, you have to address it. But if it's just a leukoma with Salzmann, I wouldn't do anything else. I'd just do a dalk.
Yeah. Thank you.
Yeah.
Thank you, Rishi.
Thanks.
Any questions? Till the time Dr. Prateek is getting his thing ready. Rishi, any tip for opening up that thing? I still get scared when I have to do that slash.
For the brave slash, I
Yeah.
think one of the important tips is if you can put a viscoelastic on the surface and mark the point of entry where you're going to make the brave slash, and just put viscoelastic. I think that makes the escape of air a little slower, and that has made a difference in my cases. And of course, when you're going in, just keep the blade in one direction. If you tilt it and you allow the air to escape, that's when the Descemet's will come back. So if you just keep it, the air doesn't really come so easily. It comes out gradually. You can go with a keratome. Yeah. So it's been described by Professor Sarnicola. I've not really tried it, but it should work. Yeah. I don't do much big bubble only nowadays. I just do this technique most of the time. Yeah. It's basically you'll start seeing the layer. Stroma has that whitish fibrous kind of a look, no? Once you reach the predesmatic layer, you'll start seeing a more clear kind of a layer. So you will see stroma. Matlab, basically, it's not that it's not there. I think it's adherent at the peripheral area. So I've seen that glassy layer even in very peripheral dissections. ऐसा नहीं है. So you can do it.
So, do you find any difference in the frequency of DM perforation in type 1 bubble and type 2 bubble?
Yeah. So basically, if you get a type 2 bubble, it is going to be a complicated surgery. If you've got only a type 2 bubble, you could theoretically dissect the entire stroma off using some sort of a manual technique and then just puncture the type 2 bubble and leave it.
So, is there any tip to get type 1 bubble, not the type 2 bubble?
So you have to select the cases carefully. In my experience, deeper scars, macular dystrophies, these are the cases where you end up with type 2 bubbles more often. Keratoconus is very rare actually. And the second important thing is you have to be in the right plane when you're injecting air, and don't see how your air is going in the stroma. If it is tending to come back into the cannula, into the track of your cannula, or if it's going circumferentially, then you're not in the right plane. Then probably instead of continuing to inject, you need to change your location and try again.
Thank you so much,
Thanks.
Rishi. That was really wonderful. May I now request Dr. Prateek to please come forth and tell us about the posterior lamellar keratoplasty, DSEC, DMEC, when and how.
Thank you, Dr. Shweta, for making me part of this wonderful instruction course. I shall be covering posterior lamellar keratoplasty, DSEC versus DMEC, when and how. So the indications for posterior lamellar keratoplasty, we all know the endothelial dystrophies and pseudophakic bullous keratopathy topping the charts. And in the last couple of decades, we all know that posterior lamellar keratoplasties have really picked up among corneal surgeons over conventional keratoplasties, full thickness keratoplasty, because of obvious advantages. The reason between this debate of DSEC versus DMEC is based on the thickness of the lenticule which we insert. In DSEC, we have donor stroma also involved, so the thickness is around 70 to 150 microns, depending on whether you are doing an ultra thin DSEC or a normal DSEC. And in DMEC, it's pretty thin, something between 10 to 15 microns. So because we don't have the donor stroma involved in the DMEC tissues, it offers a perfect anatomical replacement of the deceased stroma, deceased endothelium, and offering our patients a much speedy and better visual recovery and with a comparable endothelial cell loss. Even the post-operative steroid dependence is pretty less. We can wean off the steroids pretty early and shift to soft steroids in DMEC patients. But there is a flip side that there are challenges involved in every step of DMEC, and especially in Indian eyes where you have hyperpigmented iris, darkly pigmented iris. Everything goes fine till your DMEC scroll is in the tube, but the moment you inject it inside the eye, things become a bit difficult because of the visibility issues. Coming to the pre-operative evaluation, which involves patient selection and donor evaluation, we select usually these patients of posterior lamellar keratoplasty we do under peribulbar anesthesia, sometimes requiring general anesthesia. The patient must be able to lie supine. Especially it becomes important for DMEC patients. If it is not, patient is not able to lie supine, you will require rebubbling procedures. And anticoagulation profile, again, it's very important to check if the patient is on anticoagulant, because you have to stop that at least 3 days prior, because even a small bleed in a DMEC case intraoperatively would lead to difficulties during unfolding of the tissue. patient selection in DSEC versus DMEC, for initial cases at least you have to be take clear cut cases like Fuchs or clean pseudophakic keratopathies, because if you have scarred corneas, cornea clarity is not good, then it becomes difficult during intraoperative manipulation. Anterior chamber complexities like presence of vitreous in the anterior chamber or dense peripheral antisynechia, again these cases are not good for the initial DMEC cases. Bubble management, what you can do is in beginning of your case you can inject air in the anterior chamber and see how it is behaving. If it is staying well, then it's good. If it is going like in cases of no capsular support, the air might go behind the iris and the vitreous. So these cases will not be good for the initial cases of DMEC surgery. Donor selection, again the rim size, which is pretty important for DSEC cases, is not that important in DMEC donor tissue. The older is the better, like 40 years 45 years plus age, which is phakic eye with a good cell count, and non-diabetic eye would be a preferred donor for a DMEC. Younger donors tends to form a very tight scroll, which is difficult to manipulate during your DMEC surgeries. The tissue preparation in DSEC is pretty straightforward. We all know this is an artificial anterior chamber, this is a plastic one, although we have steel and other also available in the market. So you need to put the tissue endothelial side down, and then put the cap and tightly screw it. And you can push BSS or cortisol inside to make the glove to make the antechamber firm, and you can start your dissection at the limbus with the help of a 350 microns or 400 microns, depending on your comfort level. Initial incision is like 3 clock hours. This is 400 microns guarded knife which is I am using, and then you can initiate the incision with the help of a crescent. And with the other hand you can actually tilt your artificial anterior chamber to follow the corneal contour more easily. Then this is a straight lamellar dissector which you help start dissecting till the center of the cornea, and then once you reach the center you change it to a curved lamellar dissector, and you dissect from edge to edge and from limbus to limbus, making sure that you don't have any undissected tissue. And then you mark the center and the incision site, and gently you unscrew the assembly. For a ultra thin DSEC, you can even make a second pass to get donor tissue, which is donor lenticule, which is less than 100 microns. Then you put it endothelial side up on a Teflon block and just punch it to the desired diameter. The diameter depends on the white to white diameter of the recipient, and then you can check whether your dissection is complete or not. And this is pretty much the manual preparation of that DSEC graft. Coming to DMEC preparation, again you need to first mark the center, and then you can put the tissue endothelial side up. This is like 9.5 or 10 millimeter initial trephine you can place, and gently you can put your hands and roll it in a rolling fashion. You move not to go too deep, and you create a ridge in the periphery. You can just stain with trypan blue so that you see this ridge, and then you in the peripheral rim of this donor endothelium you can just remove it, and then start with the DMS scorer. In the all around you go like this. Another important technique is you can use your other instrument to give a counter pressure on the stroma while you are dissecting, going circumferentially to score the Descemet's membrane. So this helps you in scoring the Descemet's membrane all around. Once it is complete, you can peel it, start peeling. I usually peel it from 2 or 3 sides, and from one side, and then diagonally opposite side you start peeling. And once your peeling is complete, you deposit your Descemet's membrane endothelial complex back, and then you can take an 8 millimeter or 7.5 or 8.5 depending on the white to white diameter of the recipient, and you just put it and gently tap on the surface. Again, you don't have to push all through, you just have to tap it, and gentle tapping motion will release will cause a separation of the Descemet's membrane from the peripheral Descemet's membrane. And then you remove the peripheral frill, which is between 8 to 10 millimeter, and you remove this frill, and then you can make just curl it, and you can just make a window for doing your marking with a 3 mm trephine, punch biopsy trephine. And once you have done this, you can just and you can put your stamp. It is very important to stamp, and it's very important to not lose this small 3 mm cap, otherwise your surgery will become very difficult. Then you stain it. I stain it usually for 1.5 minutes with trypan blue, and then you can just took this assembly and float it in BSS, and your tissue scroll is ready to be loaded and injected. You try to orient it in the correct direction before you load it in your injector system. These to and fro movements helps to unfurl the tissue, a tight scroll, and then it can be injected. Recipient preparation will remain the same in both DSAC and DMAC, except that for DMAC you require a larger recipient descemetorrhexis as compared to DMAC, where you can have a same size of descemetorrhexis in the graft size, and a peripheral iodectomy, inferior peripheral iodectomy is mandatory in all cases of DMAC. Graft insertion, again for DSEC, it's pretty straightforward, where you can use either Busenglide or Endoglide, or you can directly insert with the help of a cystitome, like in this case. But with the help of cystitome, you have to have at least 5.5 mm incision, where you just take on the your donor tissue, you coat your corneoscleral part with the HPMC viscoelastic, and you take your donor tissue and put it on the bed, endothelial side down. Once you have this tissue endothelial side down, you can gently engage with your cystitome and straightforward push it inside the recipient part. Then gently put some BSS and some tapping over the cornea. It will unfurl, and your case is complete. With a suture, you can put a suture if you want. In cases of DMAC, it's again, I usually put an air bubble while I am doing my in the anterior chamber, while I am preparing my donor tissue. This stops any kind of bleeding which is there, and then you can inject your donor tissue. I'll just forward it, and you can just inject your donor tissue, and with gentle tapping movements, you can make slowly unfurl it. There are various maneuvers which have been described, and I'll just forward it, and with gentle tapping movement, and once it is unfurled, you can just inject and get away with your DMAC. So you can give wonderful outcomes, but still you have to learn DSEC, because it's not only apart from the other indication that I discussed, it's a beautiful backup procedure also. In case of failed DMAC, you can definitely go ahead and do a DSEC in your patients. For those who have already learned DSEC, I think the same principle of donor manipulation do not applies to DSEC. You have to unlearn the principle and learn DMAC in a different manner. A wet lab practice helps a lot, and choose simpler cases initially to gain confidence. I thank you for your patient listening.
Thank you, Pratik. That was a very nice talk and lovely videos. So we all know that the DMEC is probably one of the more difficult surgeries for corneal surgeons, and it does have a learning curve. So in your experience, how many cases does one really need to do to be past the learning curve? And what tips do you have for learning DMEC beginners?
I think one important thing as a private practitioner, when you are doing DSEC and DMAC, starting DMAC, I used to keep a backup cornea, because if something happens, my tissue scroll is not prepared, I at least have a backup cornea. And if I get away with a DMAC, then you can use that cornea in the patient. So that I initially used to do. Coming to the numbers, I don't think there is a specific number, but I think to be comfortable with the tissue manipulation, all you have to do a lot of wet lab practice. That actually makes you very comfortable about the tissue manipulation. If you apply the same principle of DSAC insertion on DMAC, then it's not going to work. And it's entirely different fluidics inside once you insert your graft. So I think maybe 20-25 cases you need to get a good idea of how the tissue unfolds inside your cornea.
Yeah, I think one more thing which I did in my learning curve is tell every patient that this is the two surgery.
Yes.
So you will require some second intervention. Either it'll be rebubbling or
Yeah.
desec or
Very practical thing,
redemake.
yes.
So if you prepare the patient, mostly दो होंगे.
No,
And if you are lucky, you may get away with one.
yeah.
Then both you and patient are at peace,
Yes.
and patient is much more accepting.
What injector you have used to put that?
That's a glass injector. It's from Joja Surgical.
For DMIC graft preparation, you have to show the ideal age is 45 to 70.
Yeah, yeah.
I would like to ask, what is the idealistic age for
50 to 60 years.
50 to 60
years.
years.
50 to 60?
Yeah.
Because that's a perfect combination of open graft and good amount of endothelial cells.
And it has to be phakic.
Thank you so much, Pratik. I have one question for you, but I'll ask Dr. Vinay to please come and get his slides ready. So I have stolen this question from Dr. Rishi, actually, Pratik. Why are you still marking F and not P?
It's not about marking F or P. It's just that I'm more comfortable. I started with P, now I'm using S. It's like that.
जो मिल गया.
जो मिल-
Still, there is a confusion between FS and P.
I think basically it has to be some asymmetric letter. That's it. Doesn't matter. It could be a 5, it could be 2 also.
Thank you so much. Dr. Vinay, I would request you to please go ahead with your talk about everything about patch grafts.
Thanks, Sweta. So, what are patch grafts? A living or synthetic material used to repair a defect. That is a definition of patch graft. So, ideally, it should provide volume replacement where it is required, provide good tectonic support, should maintain the integrity of the globe, and should promote healing or should result in scarring. So, patch grafts can be synthetic, and what we most commonly use is the cyanoacrylate glue. Biologic glue is fibrin glue. Then, as you can see in this, all you see here can be used. You can use the cornea, you can use the conjunctiva, you can use the tenons, monocular biologics, amniotic membrane, mucous membrane graft. Then you have a whole set of other things which I have never used actually. Pericardium, periosteum, fasciolata, split skin graft. All these have been described. So glue, again, a lot of indications, and basically it can be used for on the surface. Okay, for any case where there is a thinning or a descemetocele small perforations, 2 to 3 millimeters can be easily handled. Then lacerations, also all sorts of things. The mechanism is these are all liquid monomers which kind of causes results in polymerization when it comes in contact with water. So water is essential, but then we always dry the surface. The procedure mostly is done under topical. What is most important when we do glue is to debride the surface of the epithelium and the necrotic tissue, and then dry it. There will always be a thin layer of fluid or water whenever, even if we dry the maximum. So apply a thin layer. Various techniques are there, and this is the most important step in any wherever you glue. Debride, so you get a healthy or as normal stroma and surrounding structure. Then the glue, this is the handle of a PVS sponge. You can apply a thin layer, or even you can use it using a small cannula or 30 gauge needle. So basically you leave it till it heals. And how do you know whether it has healed or not? Is with the vascularization. So that is the disadvantage. Poor biocompatibility, more inflammation, induced vascularization, and can be used only on the surface. So but tectonic strength is quite good, cheap and easily available. Now, fibrin glue, on the other hand, is biologic. It's nothing but basically the clot devoid of RBCs. The problem here is, it is a little expensive. Tensile strength is very low, and it gets degraded fast as it is biodegradable. Usually, it is used as an adjunct with other things and not as per se as something to seal anything. Now, when you compare cyanoacrylate and fibrin glue, the main thing is fibrin glue is less expensive, and cyanoacrylate is less expensive, give good tectonic support, while fibrin glue is used as an adjunct with other things. So Then amniotic membrane, various uses of this. We are concerned about the tectonic part where it can be used as a multi-layered. Here again, you have to debride the surface well, and then using fibrin glue you can fix it. Multi-layered, the thinner area you can actually put stacks of amniotic membrane and then cover the whole thing with amniotic membrane. Can be used for small perforations also. The advantage, as we all know, it can act as a basement membrane replacement, so epithelialization happens. Multi-layered helps in stromal augmentation slightly, can act as biological bandage, has got properties like anti-inflammatory, antibacterial. It's non-immunogenic. The disadvantage for a tectonic procedure is that it's of low tensile strength. Availability can be an issue, and it has to be, it is reasonably expensive. Then conjunctiva can be used as a pedicle graft or as a total hooding, Gunderson's flap. Various indications again as therapeutic in infective or non-infective ulcers. Then if there is a perforation, you can use a tectonic on the cornea, or even on the sclera you can mobilize it. Problem is when you use it on the cornea, it can cause vascularization, affect vision, and then cosmesis is definitely an issue here. Then comes the major one where we use cornea for tectonic purpose. It is reasonably good because you are not really bothered about the cornea quality, or then it can be used when it is stored in any medium including glycerin. Any case of melt or thinning of the cornea, sclera, or any structure, we can use cornea. That is the advantage of cornea. Provides good tectonic support and easy to handle because we are used to handling cornea so much. So handling, dissecting is quite easy. The disadvantage is again availability can be a problem. Then when we use it, we have to decide whether you need a full thickness or a partial thickness, a lamella. In various conditions you may have to fashion it into different shape. Dissection basic principle is we need to have create vertical edges and then create the graft of it into the defect and fix it with either fibrin or sutures. This is a peripheral ulcerative keratitis where we had to do a D shape, and as Rishi showed, most of these cases you don't need a sharp dissection to remove the deeper layers which already inflamed. The adhesion will be very loose. You can just use a iris repositor. And this was sutured. And then this is another case where post-pterygium scleral melt where cornea was used. So for sclera also you can use cornea as a patch graft. The sclera as a patch graft is used when there is a problem with the sclera, not a good option for corneal thinning. The advantage is provides excellent tectonic support. We can store it for long, so the availability is much easier than cornea. Disadvantage again, many of the eye banks now doesn't process sclera, so availability of sclera is little difficult. Here also we have to decide whether it's a lamellar or full thickness which we need to use. And one important point when using scleral patch graft compared to cornea is that this has to be covered with a vascular structure. Either vascular tenons or conjunctiva has to be used, because otherwise the exposure will cause scleral melt, because it is going to take time for epithelialization here. So other group is corneoscleral, where you can use a cornea and sclera together, and this is a post trab infection of the section, and terrible probably melt of the avascularity of the conjunctiva. I don't know whether it's the conjunctival problem is because of the overuse of mitomycin, but then within 2 weeks of surgery, whether that happens is a question. So here we have used a corneoscleral graft, the sclera to match the limbus actually, and then the scleral part is again covered with the tenons and conjunctiva. In addition to any therapeutic, at times you may need to use it for cosmesis also, like in this girl with dermoid. Again, here also we have used a corneoscleral, the sclera to match the sclera, the limbus to limbus. Then finally, the new kid in the block, the tenons, which has come up now. Again, it can be used for corneal thinning and descemetocele. It is said that up to perforations of 6 millimeter, you can use it. The advantage is it's always available, autologous or non-immunogenic, inexpensive because you're taking it from the same eye. Okay, gives good volume replacement, and it's an excellent option in uncontrolled autoimmune and inflammatory conditions of the eye with melt. But it is not an option in infections. Okay, and the tectonic support provided is very not as good as the other ones. Okay, so here once you do the transplant, if there is a perforation, you have to make sure you leave the eye a little soft. If you really form the AC and tighten the globe, there will be leak, and it actually favors, and you will have a flat globe flat AC the next day. What I generally do is I generally dissect around the area of thinning or perforation to create a pocket, and then tuck it in, and then take overlay sutures. Of course, if possible, do a fibrin glue at the base so your tenons is stable there. Otherwise, tucking in can be a little difficult. Yeah. Thank you.
Thank you so much, Dr. Vinay. That was a really very extensive talk. You've covered almost everything. I completely agree with you, that tenons really doesn't do well in infections. But any thoughts on it as to why it doesn't do well?
Probably the organisms spread to it. I don't know.
Yeah.
We've never actually looked at why. I mean, we've not taken the tenons and seen whether that grows organisms or what is happening there. No.
Yeah, because I agree with you. It doesn't, that's not an option that you really want to consider when you have an infection cases. And as you rightly pointed out, I think scleral patch graft, the most important thing is covering it with a vascular pedicle, getting the tenons and conjunctiva over it really, really helps. Rishi, I think you have a question.
I have a small question, Vinay. In peripheral ulcerative keratitis, specifically Murins, we know that the melting happens in the peripheral cornea and the sclera is perfectly okay, right? Do you think there could be a case for using sclera in the peripheral cornea? Because any peripheral corneal graft you put will again eventually melt if the disease is still active.
See, in any of the peripheral ulcerative keratitis, whether it's Murins or other thing, unless it is a frank perforation, you have to get the disease process under control before you intervene.
Agreed. So if you have done that and then you're going to do a graft, do you think there could be a case
Does
to
it
put
really
sclera?
work? I don't know. I've never tried it, but then
I actually heard a free paper about it somewhere. That's the reason I'm asking.
That's an interesting concept, but cosmetically it is going to be horrible.
Yeah,
But
it won't
I
look
think
good.
I think Rishi, here we are dealing with an autoimmune condition. So the minute you are putting somebody else's tissue in the body, probably the autoimmune thing will not work on it, and it doesn't matter whether you're putting a cornea or a sclera because this is somebody else's tissue. And
So
PUK
it
is
will
an
anyway.
autoimmune. Yeah, PUK is an autoimmune disorder. So your body is fighting against your tissue. So
Right.
probably I don't know. Dr. Geeta, you have any thoughts on that?
The general assumption in Murins and PUK is that because your corneal autoantigens have been replaced by an alloantigen, the target over there is now being replaced, and therefore the risk of melt in the transplanted tissue is much lesser, and the melts that you get is in a newer area rather than in the affected area. But yes, this is an area which we could explore further.
Thank you.
Thank you so much.
I'll invite the next speaker, who's also the chief instructor of this IC, Dr. Shweta Agarwal. And I think her area of interest is very vast. She does right from the surface to the endothelium, I think, and that's why this IC. But she's going to teach us about therapeutic penetrating keratoplasty without surgical adjunct, surgical pearls.
Thank you so much, Rishi. And coming to the last talk of this IC, well, therapeutic keratoplasty, when, what, and how to do. Well, we all know that TPK is usually done in patients with infective keratitis. In cases where there is worsening despite a maximum medical therapy, where there is an extensive corneal involvement, a threat to global integrity, or corneal perforation, or the patient is presenting to you with a scleral involvement. The primary goal is to debulk or eliminate the microbial load to restore the structural integrity. Secondary would be a visual rehabilitation. Well, a lot of factors which will influence your surgical plan, starting with the age of the patient, the extent of infiltration, whether it is limbal, scleral involvement is present, not there, infective organism, how resistant it is, and presence or absence of impending melt or perforation. Now, these are the basic steps when we talk about a therapeutic keratoplasty, and let us go through each one by one. Beginning with anesthesia. So if you have a patient who's a child or an anxious patient, or patients presenting you with a large perforation or a large graft, post-victimized where you're expecting too much of a thrust, a general anesthesia would be preferred. Otherwise, you can go ahead with a local anesthesia. Flaringa, well, it is primarily used in patients with perforated eyes, in eyes with larger grafts, impending perforations, and post-victimized. Well, at SM, we prefer to use a Flaringa in most of our cases. Now, how do we do it? We can use either a nylon or 7.5 grit, and what we need are 4 to 6 to make sure that the sclera doesn't collapse. And the size of the Flaringa can be 2 to 3 millimeters larger than your graft toe junction, so that it doesn't interfere with your suturing. Well, if you have patients presenting you with a pseudocornea or a perforation, before you go ahead with trephination, some kind of tectonic support will help stabilize the globe. So you can use either a cyanoacrylate glue, or in this second patient down that we are seeing, this patient was a case of chemical injury who presented to us with a large perforation of around 6 millimeters. His lower edge or the lower limbus was stuck to the lower lid. Now, before we would do a therapeutic and we would need the inferior limbus to suture the graft, we had to release the inferior symplifron. So here we sutured the bandage contact lens to the perforation to give the tectonic support, and then went ahead with releasing the inferior lid and then a routine therapeutic graft. Now, as far as the trephine size is concerned, as in the host, you need to involve the entire involved area, a 0.5 to 1 millimeter clear margin. As far as the donor is concerned, again, 0.5 to 1 millimeter larger than the host. It'll help facilitate better formation of the anterior chamber. And again, any graft size more than 10, we prefer a difference of 1 millimeter, again, for a better anterior chamber formation with a larger graft. So the trephine size and location varies with the size of the infiltrate and the site of the infiltrate. It could be central, it could be peripheral, it could be eccentric, it could be a total. Now, lens. You really want to preserve the lens because you don't want the anterior and posterior chamber to become one and the infection to trickle from the anterior to the posterior cavity. You can, if it's a phakic patient, you can give the patient a pre-op IV mannitol to reduce the vitreous thrust, a Flaringa to prevent a sudden collapse, and a careful peeling of the inflammatory membrane in the pupillary area so that we don't open up the anterior capsule. Exceptions, however, are patients who present to you with a perforated ulcer or a pseudocornea with the bulging lens or an intumescent lens, where we would have to sacrifice the lens to form the chamber. But in such cases, again, we would try and see if we can keep the posterior capsule intact. Now, all these eyes are significantly inflamed and they will develop some kind of angle closure glaucoma secondarily. So you would prefer to have 2 large iridectomies. You can use either a Vanna scissor or a vitrectomy cutter to make that. Donor suturing is always interrupted. These are inflamed eyes with irregular healing, so you do not want a continuous suture. You can use either a 10-0 or a 9-0 nylon, and this number depends upon the size of the graft. Anything less than 10, usual recommendations are 8 to 12 sutures, 7.5 to 10 millimeter grafts, 16 sutures, and anything more than 10 millimeter would be around 24 sutures. Again, this gives a better convexity and a better formation of the anterior chamber. Now, the basic steps that we just went through, a video summarizing that. You first measure the size of the infiltrate, a 0.5 to 1 millimeter larger. Anchor the Flaringa with a deep episcleral bite using an 8-0 nylon. Trephine the host bed. We usually don't want to go a full thickness in an inflamed eye because most of the times the anterior chamber is shallow to flat. Careful entry. Inject visco to form the anterior chamber. Excise the host button. Very careful peeling of the pupillary membrane so that we don't open up the anterior capsule. This is really important. You need to remove this, otherwise the patient will end up with a pupillary block glaucoma. A good large iridectomy, 1 or 2. And then suturing of your graft with either a 9-0 or a 10-0 nylon. Since this was a larger graft, we have taken 24 sutures. And bury your sutures and remove the Flaringa. Well, we do have some special case scenarios, patients with endophthalmitis, where you might have to do a therapeutic graft with your VR colleagues. In such cases, we prefer a general anesthesia because the surgery is going to take a little longer time, and you would need a temporary capro. What we need to remember is the sizes which are available as of now are 6.2, 7.2, and 8.2. So you need to plan your surgery accordingly. Well, the capros that are temporary capros that are available are silicone and the landers with a PMMA. The silicone is a soft, pliable keratoprosthesis, whereas the PMMA or the landers is the hard or the rigid one. Multiple uses is going to cause scratches in landers, and it might result in torn edges in your silicone capro. The suturing in silicone capro is much more easier. It just goes inside into the graft, into the defined edge, and you suture it to the defined edge of the hose. But the PMMA is a larger capro, so you need to suture it wherever your end of the capro comes out from. It facilitates more clearer view of the procedure chamber and helps the VR colleague finish their part. After that's done, just remove the temporary capro and go ahead with the routine TPK that you have planned for. Now, if you have a patient with a refractory organism like pythium keratitis, or you have a limbal involvement, or you have patients presenting to you with a recurrent infection following a therapeutic graft, what we usually advise is a TPK with surgical adjuncts, that is a cryo-alcohol therapy. Here we swab the involved surface with a 99.9% alcohol for 30 to 60 seconds and use the nitrooxide cryotherapy, the same that our VR colleagues are using. It is a Rittel tip that we use. We place the probe for around 7 to 8 seconds for an ice ball of around 1 millimeter to form around the tip, followed by a slow thaw. The video just showing that the absolute alcohol soak swab is just moved around the area of involvement. Wash it, measure the area of involvement. This was around a 17 millimeters graft therapeutic that we were doing. A single freeze thaw cryotherapy at the edge where we are going to trephine. And once this is done, this is followed by a routine therapeutic graft, a flaringa, and the routine surgical steps that we do. Excise the host button and replace it with your donor graft after doing a good iridectomy. This patient was phakic, and we were able to salvage the lens. To summarize, we all need to plan our surgeries well. You have to anticipate complications. A pre-op counseling plays again an important role in patients with therapeutic, where they need to understand about the possibility of recurrences and that the graft is not being done for vision. It is being primarily done to debulk the infection. A timely intervention will definitely help us improve our outcomes. Thank you so much. Any questions?
Ma'am, which suture do you use to secure temporary capro?
70 Vicryl.
For your sclerocorneal graft, you're using 80?
90.
90.
90.
Very nice talk. Do you use the adjuncts in every case of pythium keratoplasty?
Yes, Rishi. Now that we have enough of our cases to show that it really works, if we are doing a therapeutic graft, definitely yes.
Only for pythium.
Only for pythium. And if we have a patient presenting to us with a recurrence,
Right.
we have done cryo-alcohol therapy for patients with acanthamoeba. We have done cryo-alcohol therapy for very refractory fungal scleritis, where almost 360 degrees the patient had presented to us with a fungal scleritis, one-eyed patient, and because of cryo-alcohol therapy, actually, we were in a stage where we were going to eviscerate the eye, but we thought, okay, one last shot, and we were still in those early stages where we ourselves didn't have full faith on the cryo-alcohol therapy, but we were able to salvage that eye, and he's 6'9" now.
Lovely. That's
Yeah.
nice to hear. So do you think we could use these principles even say you're doing a scleral deroofing for a fungal scleritis, which is very focal?
Absolutely.
Could you just apply alcohol
Absolutely,
and do a little
absolutely.
focal cryo in that area?
Absolutely. In fact, after
Yeah.
that case, we have started doing it. So patients with a fungal scleritis,
Yeah.
when we are taking up the patient, you are anyways taking up the patient in the OT, and alcohol is something which is readily available. It's very cheap and keeps everybody happy. So yes, we use it very often in OT, especially with patients with fungal scleritis.
Thank you.
Thank you.
And what is your post-op regime in therapeutic PK done for fungal etiology?
Fungal keratitis patients will be on natamycin, or we usually start with one drug. So it'll be natamycin every 1 hourly, and along with cycloplagics and lubricants. If required, voriconazole, based upon if we've been, if we have done a sensitivity and we have found something. Otherwise, usually natamycin or voriconazole. And pythium, we as of now post-op give the patients topical azithromycin and linezolid. Yes, we do use, especially in patients, even after the cryoalcohol therapy, we have noticed that some of these patients develop a significant inflammation intraocularly, and we use 2% cyclosporin 3 times or 4 times a day in patients. Even post-therapeutic, if especially fungal TPKs where you have too much of intraocular inflammation, we've been using cyclosporin 2% and it works quite well. Thank you so much.
We now invite Dr. Rakhi Kushmish for her keynote address. AIOS Cornea Award, Bihar Ophthalmological Society, on miltefosine related keratitis, clinical characteristic and management.
Good morning, everyone. First of all, I would like to thank AIOS Scientific Committee for giving this AIOS Cornea Award to this paper. So I have no financial interest. So miltefosine is a phosphocholine analog originally developed as anti-malignant drug, and it was recommended by WHO as the only oral drug to treat all types of leishmaniasis since 2002. So we all know that leishmaniasis is a group of diseases caused by parasitic protozoa of genus Leishmania, and it is transmitted by sandflies. And the most common and serious form of it is Kala Azar, known as visceral leishmaniasis, and in 10 to 20% cases of Kala Azar, there is a residual, or you can say the inadequate treatment. The post-Kala Azar dermal leishmaniasis developed, which is a skin sickle, and it is characterized by skin rashes and tends to appear 2 to 3 years after the treatment of Kala Azar caused by Leishmania donovani. And it is endemic in an area of Bihar, Jharkhand, and some part of West Bengal and Orissa, and its estimated prevalence is ranging from 4.4 to 7.8 per 10,000. So there are 3 drugs available to treat this condition: miltefosine, sodium stibogluconate, and liposomal amphotericin B. But the miltefosine is the only oral drug which is highly effective against PKDL, and its recommended doses are 100 milligram per day for 84 days. Now this is considered as a safe drug with few adverse reaction like gastrointestinal symptoms, and there are few reports from India and Bangladesh who have reported some ocular complication in these cases, but the clinical impression in all these studies varied from Murren's ulcer to scleritis. There was no consistent feature among all the studies, and the clinical feature of keratitis, its course and management has not been established. So this paper was done to discuss the diagnostic clinical features, its progression, and the management in 6 consecutive PKDL patients treated in a single center. So this study was retrospective, conducted between April 2018 to December 2020, and which 6 PKDL patients were recruited who were receiving miltefosine. Studies was approved by IEC, and consent was taken from all the patients. In evaluation, we included the complete medical history, focusing on the drugs used to treat Kala Azar and PKDL. We have documented the dose and duration of treatment and the onset of keratitis after initiation of the drugs, and the detail of other drugs used for ocular complaints were also mentioned. We also did the casualty assessment of adverse drug reaction to miltefosine by WHO UMC criteria. So in workup for keratitis, we included the size, location, pattern, depth and extent of stomal infiltrates, extent of edema, presence or absence of corneal edema or hypopyon or any epithelial defect. We did microbiological evaluation of all the corneal samples, direct smear examination and culture. PCR was also done to rule out any presence of Leishmania donovani. RK39 and skin biopsy tests were done to check whether the disease is active or now it's completely healed. So in results, we found first case was bilateral keratitis, and he was a 31-year-old male. He was taking this drug for 48 days, and after appearance of ocular symptoms, he continued this drug for another 17 days. And at the time of presentation, we found that there was a paracentral dense full thickness infiltrate present in both the eyes, rapidly progressive and involving in the center of the cornea. And there was a thinning in the right eye, so we performed PK in this eye. This was a first case. We were really unaware of the condition and how to treat. We were not aware of this. So we started all topical antibiotics and sent the sample for micro examination. When the test came negative, we started oral steroid, and since there was a thinning, we started doxycycline also. In left eye, we started topical as well as oral, and both the eyes resolved very well after the use of steroid, but it took a very long time, 5 months. Second case was also bilateral with very typical presentation of this drug complication, paracentral full thickness infiltrate involving the whole circumference as well as the deeper area, giving the impression of annular ulcer or ulcerative keratitis. So in right eye, we did PK in view of thinning in the periphery, and left eye was responded very well to oral and topical steroid along with antibiotics in 4.5 months. Rest 4 cases had a common feature, like they were all unilateral, and they were also on miltefosine. They stopped the therapy after appearance of ocular symptoms, and they were all resolved with the use of topical steroid and antibiotics. We didn't use oral steroid in these cases. So overall, the results were ocular symptoms were common in all the patients: pain, watering, photophobia, and diminution of vision. And there was ring-shaped keratitis, full thickness paralimbal infiltrate, which was common in all with the hypopyon and edema. 2 cases had bilateral keratitis, 4 cases had unilateral. Laboratory test, smear culture, PCR were negative for the organism or any other microorganism, but RK39 and skin biopsy were positive, which says that the disease was active and the parasite was still in the skin. So management was common in all the patient. Discontinuation of metformin and initiation of corticosteroid were the mainstay of treatment, and casualty assessment showed that this can be a probable association of adverse reaction to miltefosine. So we found a consistent pattern of keratitis in all the case along with clinical course. So we could divide this keratitis into 2 groups. One is the early stage and second is advanced stage. In early stage, there was annular keratitis with intervening clear area from limbus and the infiltrate. In advanced stages, the infiltrate extended both centripetally and circumferentially and involving a look like ulcerative keratitis. As far as mechanism is concerned, it is not very clear, but some studies have hypothesized that drug might be very toxic to the ocular tissue because of its long elimination half-life, or it could be autoimmune reaction because it responded very well to steroid. So the management were common in all the cases, and by stopping the miltefosine immediately and excluding the infectious etiology, initiation of early anti-inflammatory therapy in form of steroids, and deferring PK for the complicated cases, because both the in cases where we didn't do any surgical intervention, that those cases performed really well. So we emphasize the need of strengthen the pharmacovigilance program in endemic areas for ocular examination in the patients who were taking miltefosine, and its course, like early diagnosis and discontinuation of therapy is really important. So we published this paper in BGO, British Journal of Ophthalmology, and after that, in 10th February 2022, WHO took this case very seriously, and they published some result that the periodic ocular examination should be done in all the patients who are taking miltefosine for this condition. And after that, they made a multidisciplinary technical group, and I was also an observer in that group. And after that, very recently in 12th April 2023, they published the whole report with some annexures on tables that how to follow up these cases and what to be done if something happened to the eye. So and they give information to all healthcare workers, to patient, and they also emphasized the strict active surveillance in these cases in endemic areas. Thank you so much.
Lovely presentation. It is really enlightening, and it was interesting to see that miltefosine has been described as a treatment for acanthamoeba
Acanthamoeba keratitis,
and
right.
the infiltrate also looks like a ring infiltrate, just like
Yes.
acanthamoeba. So it's very good information for. I didn't know that it could cause this
Yeah,
complication.
thank you, sir.
Thank you.
Thank you so much, Raki. Seriously, a beautiful presentation. Have you otherwise used miltefosine for any patients with acanthamoeba or?
No, not yet.
Thank you.
After this, I think I'm not going to use it.
Yeah, because there are papers being published
Yeah,
for.
there are some papers with miltefosine acanthamoeba keratitis, but some has shown worsening also. Like one from LVPI, they are doing some pilots study of topical miltefosine in acanthamoeba keratitis, and they stopped it because of the worsening of keratitis in all 5 cases. So probably I'm not sure whether it is working or not, and still we are not clear whether this organism present in cornea or these are the sidal effect. We still not sure.
Thank you so much, Dr. Raki.
Thank you, ma'am.
I think we are at the end of the session. Any further questions? Anybody? Can I ask the speakers to please come on the dais for a group photo, please?